don't do theory. I don't do fluff. I'm not interested in hypothetical thinking. I'm interested in, trying to prove something with a practical method so that people can just apply it. The reason why is because you're just pinching it. You're further impinging someone's impingement syndrome. And then they get hurt, and then they quit. And then they show up here years later, and I listen to them complain to me about how the physical therapist hurt. I see them in here. And I see what the medical system's missing, because they tell me all the time, I've seen everybody, nobody knows what's wrong with me. I see mechanical issues. And then, this is a mechanical issue. They will literally move heaven and earth to find the money to pay for you. There are certain conditions that are so debilitating, and they're just so tired of it that they will pay you what you are charging. The hardest part is personalities. You've seen so many different personalities. You try to get people out of their own way to keep going, and they have excuses why it's not going to work or something like that. You just got to get them out of their own way, which I cover in my courses. Yo, everybody, what is up? Your friendly neighborhood physical therapist, Dr. Whelton, coming to you from just outside the beautiful, nice day out there. I just took a walk. I know it's snowing and it's cold. I just got back from Massachusetts over the holiday, and it was really cold. But it is not here in Florida. If you are new to follow me, I am a physical therapist that has a chronic pain clinic. I call it the Unfailed Everything Clinic. And the reason why I say that is because there's usually not a week that goes by where I hear that multiple times by people. I've failed everything, nobody knows what's wrong with me, that kind of thing, right? And I get exceptional results in that patient population, have so for years. I published statistically historic papers in readership that I posted to my social media, Whelton Methods. Go look at them. And you can see the analytics of the papers that I published getting multiple times, even the biggest, not just orthopedics, medical journals in the world reads 3 to 5 years post-publication. So if you click below and join my free VIP school group, okay? My free VIP school group, that is, I teach him there much more in depth, but I also have my advanced clinical mentorship where I mentor you clinically, and you also get 59% off all of my courses, which is crazy. People love those courses. I think you'll be stunned at using these courses, because a lot of this is why those papers that I wrote made medical history. So anyways, that's that. So today and I also have my business course. So I have my business course, Cash-Based Clinic Accelerator. It's a totally different model. It's not like anything you've seen. It's a hybrid course. I use my clinical methods to open a certain type of cash-based business model that is highly successful, very different than a traditional cash-based business model. One therapist generates 7 figures in this business model, and there's not too much overhead, relatively speaking. So it is very profitable, but it's based off my methods. So I have people now doing it and loving it. And it's the most rewarding thing that I've done in my career. And I've worked with basically every type of population, special ops soldiers. I worked in the NFL, worked with NBA players, see pro baseball players. But these people are the most rewarding because they're so debilitated with this chronic pain. But I show you how I help these people. And I generally don't worry about helping these people. Anyways, that's that. Today, I am talking about shoulder pain. So I published a paper called, click the link below, click my VIP, go to my school group, join it for free. I have my papers in there. I published a paper that I talk about shoulder issues, okay? So there's a big debate in the orthopedic community about posterior shoulder impingement syndrome, or otherwise known as uh, internal impingement syndrome in here. Now, these patients, when you bring them back into a 90-90 like this, they have a pinching sharp pain in the back of their shoulder, okay? Now, it was debated what was causing what, but you know, I'm very practical. Like I don't do theory. I don't do fluff. I'm not interested in hypothetical thinking. I'm interested in, trying to prove something with a practical method so that people can just apply it. You know what I'm saying? Like one of the reasons, that's why I believe one of the reasons why my medical papers made medical history, getting multiple times of readership of the biggest journals in the world, is because everything's so practical. That's what people say about me. They're like, it's so easy, it's so practical. I'm like, yeah, well, I didn't think it was that hard to, like it's just made hard type thing. Everything's convoluted. It's lost in the left brain, round in circles we go. So anyways, in that paper, I proposed a protocol that I believe proves, that paper went viral and still continues to go viral. That paper, I believe, proves what is actually causing posterior impingement or internal impingement syndrome. And what I do, and I stated in that paper, is when I bring the person into external rotation, I push posterior and inferior like that, okay? Hold it down like posterior, inferior, and I hold it while they're in the provocative position where they actively have pain. And when the person actively has pain, and I put them into a 90-90 test, and I push the humeral head posterior and inferior, and I ask them, does that pain still in the back of your shoulder? And they say no, then you just proved what was causing it. It was a posterior and inferior capsule biomechanically. You pushed it back and down and it relieved the pain. And it's like a relocation test, right? And what that proves to you in your mind is not only did you just figure out what was causing your patient's pain, you actually just figured out what to do about it, okay? Because if posterior inferior mode relieves their pain, then you need to mobilize the posterior inferior capsule. Now, what I believe is happening there biomechanically, in my clinical experience, is what's happening. So this is the back of my left shoulder here, right? And what's happening is when you bring these people into 90-90 and externally rotate, it pinches back here, okay? And when it pinches back there, they get a sharp pain. I've seen people that are like, I can't lift my arms up over my head for years, and they get injected and all kinds of things, right? Physical therapy hurt them, right? And one of the reasons that physical therapy hurt them is I always ask, well, what did they do with you? And then I stopped asking because I didn't want to hear it anymore because I'm like, is one of the things is bilateral external rotation like this, okay? And when they do bilateral external rotation with like a rubber band in a doorway, what are you doing? You're taking an impinged labrum. Usually the labrum is getting pinched. When you're taking an impinged posterior labrum and just impinging it more, you're just jamming it, And when you jam it, then the person has an increase in pain. So my general shoulder protocol in my rehab results course, and I published some of it, my general shoulder protocol includes bilateral external rotation with a rubber band, okay? But my posterior impingement, otherwise known as internal impingement, syndrome does not have bilateral external rotation because when I do this with patients, it makes it worse. So the purpose of bilateral external rotation with my superior impingement up here, not way in the back, but up here, the purpose of that is to bring this back back in the socket. So it's too far forward in the socket, hence a tight posterior capsule. So I do it with superior impingement, that bilateral external rotation, but I don't do it with posterior impingement. And the reason why is because you're just pinching it. You're further impinging someone's impingement syndrome. And then they get hurt, and then they quit. And then they show up here years later, and I listen to them complain to me about how the physical therapist hurt. And I'm like, yeah, that exercise, exacerbates it. I'm like, I don't do that exercise with that issue. But what I find actually with posterior impingement patients, okay, is that they generally, I've seen them like in this quote, I've failed everything clinic, I call it. I see them in here. And I see what the medical system's missing because they tell me all the time. I've seen everybody, nobody knows what's wrong with me. I see mechanical issues. And then, this is a mechanical issue, I mean, technically, you could get them under, imaging and actually, but you don't need to, just put them in 90/90 test, crank it back, and if it pinches in the back, and then you relocate it back and down in the socket. So back and down in the socket, and it relieves their pain instantly. Then you just figured out what was wrong, that their impingement was caused by a tight posterior and inferior capsule. So you pushed it back and down and relieved it. Well, that means you just need room back there, okay? And down here, and relieves it. Now, the reason why I wrote up that paper and said that is in my protocols, in my rehab results course, my orthopedic protocols, the reason why I said that you should have a inferior glide as well as a posterior glide is because some patients, I used to just push back, but then there'd be some patients I couldn't get it. They would be like, no, it still hurts in the 90/90. And I would push it back and I would have a downward force, inferior glide. And they'd be like, yeah, no, that feels better. And I'm like, okay, great. We got it. So that tells me that I have to stretch not just the posterior capsule, but the inferior capsule. Okay. So when it comes to impingement syndromes in the shoulder, make sure if this person has posterior impingement syndrome and that sharp pain in here, sometimes they say it radiates down actually. But it's definitely sharp when they do a 90/90 external rotation back in here. Sometimes they'll say it's dull, achy, okay? But you can provoke it, okay? So always provoke it on evaluation, right? Make clear, always test the strength of the rotator cuff and all that. But make sure when you do that you provoke that pain, and then you can relieve it too. That's the thing I don't like about special tests in general. Like superior impingement, same thing, right? Mears test, great test. Kennedy Hawkins test, not a fan, but it's a good test. But the Mears test indicates that the person may have an impingement syndrome, right? So like that, person says, ow, right here, right? But to me, that doesn't diagnose it, okay? I don't buy that. That's not some kind of definitive diagnostic procedure. What is a definitive diagnostic procedure to me is I put the person into a Mears test, and then I mobilize posterior, inferior, relocate the humeral head, posterior, inferior, while they're in pain, up here in pain. Back down, I hold it there, and I say, what about now? Is it still there? And if they say no, boom, got it. To me, that is 100% confirmation in my clinical mind that I just confirmed that my patient pain was caused by a tight posterior inferior capsule. Now, I also stretch and strengthen muscles. I cover that in my rehab results course and in my advanced clinical group. Click below to join my free VIP inner circle. I'm talking more about that. Having said that, I do not do bilateral external rotation for the posterior impingement. For superior impingement, I do, because I'm trying to get that back and down. But when you do it with the posterior impingement, no bueno. Okay, you will most likely flare these people up, and then they quit, and then they get shots into their joint, which is now proven to erode the joint. Steroid shots, right? So we have to get these diagnoses, because otherwise, some of these crazy stories. I mean, I had 2 patients last week breakdown sobbing. I did a whole video about it. Breakdown sobbing in my clinic because one lady looked like she had a stroke. She was in a quad cane, and seeing everybody. Nobody knew what was wrong with her. Scanned up the wazoo, ablations, injections, you name it. I started thinking, this has to be a mechanical. You've been scanned up the wazoo. They've done all these procedures on you. It has to be something that doesn't show up on x-rays and MRIs, right? And sure enough, I realigned her SI joint. Her groin pain went away. Her butt pain went away. Her back pain went away. And she was able to walk much better. Okay? So, and then another lady, she just started crying because she saw my ads that I teach in my cash-based clinic, how to target these people and bring them in. She saw my ads and realized that this guy knows exactly what's wrong with me, even though I've had it for 20 years. 20 years. These people, and she's like, I can't work, I can't do anything type thing, like barely move, It's so bad, the pain, the shearing bone pain. Okay? So when we miss these things, these people like that, they go into the medical world, man, it's wild, the stories you hear. So I'm teaching people how to open and run these cash-based clinics, highly profitable. We charge $400 for 30 minutes. People say, nobody's going to pay that rent. Let me tell you something, that I've been doing this cash-based clinic for about 17 years. And people are desperate for somebody that actually knows what they're doing. Desperate. They will literally move heaven and earth to find the money to pay for you. Like, there are certain conditions that are so debilitating and they're just so tired of it that they will pay you what you are charging. Like, people are all fighting over the same patients. There's a whole patient population that is screwed. And if you know how to help these people, that's what I cover, how I get the results that I get in the quote, Unfailed everything clinic, it's not stressful for me. Actually, to be honest with you, that I don't find the clinical part generally stressful. It's not, when it comes to this. To be honest, the hardest part is personalities. I mean, you've seen so many different personalities. You try to get people out of their own way to keep going, and they have excuses why, it's not going to work or something like that. You just got to get them out of their own way, which I cover in my courses. So, that's the hardest part to me is, managing personalities. The clinical part I don't find to be, even in a quote, Unfailed everything clinic, I don't find it to be difficult. Generally speaking. Now, can I fix arthritis? No. Can I help it? Yeah. If someone's getting just pushing in their spinal cord, can I fix it? No. You should go have surgery. There are things that I can't touch, but in the general chronic pain world, I usually can fix it. Usually. But that's why my papers made medical history and readership, getting multiple times what most papers get, and not just orthopedics, the biggest journals in the entire world. Okay? Other than that, I am out. Love you all. Peace.